mass. Yeah, sorry. Yeah, so let's begin. Minute. Okay, we will do the gout because in past 3 months, the gout topic is repeated in each month, right? Like if you have done past 3 months records, you will notice about the gout, right? It's a very high yield topic for AMC. 1 minute. Sorry. So, yeah, okay. Yeah, doctor. Okay, so give me, you just need now or later. Okay, give me 1 minute. I'll share it now. I think this is in the group, but not sure because slowly. There's other doctors. Is everyone join? Minute. How is the preparations? November, sorry, not November, September doctors. Is everything going well? I'm scared. How do you feel? Okay, so let's discuss about gout. Give me 1 minute, doctor. I have a short note as well. I'll open that one. Why scared? Yeah, that's normal, doctor, to be scared, but the main thing you should be prepared, right? As I remember, I have a short note. 1 minute. Yeah, here, yeah. Everything you need to know is here. Okay, so let's start from here. Don't be scared, doctor. You will be more than fine. Okay, yeah, doctor. Yeah, doctor. I have shared. You can subscribe and on the notification because, like in all the time, uh, when we doing. Haven't you done the emergency questions yesterday, doctor? Yeah, it's okay. We will do contraception emergency questions as well. As I remember, there was 19 questions, right? Okay, so it's fine. So what is gout, doctors? What is gout? Who can tell me what is gout? So here, gout is an inflammatory arthritis caused by deposition of monosodium urate crystal due to hyperuricemia, right? What are the features that we can see in gout? Who can tell me, doctors? What are the features we can see in gout? Quickly tell me. What are the clinical features of gout? Mm-hmm. Okay.
There would be sudden onset pain in any of the joints, severe joint pain,
Mm-hmm.
mostly metatarsal, first metatarsal,
Mm-hmm.
and there will be erythema, there will be swelling, and sometimes fever can also be present.
Yeah.
Sometimes.
Thank you so much, Doctor. You are absolutely correct. So we can see acute onset severe joint pain, swelling, and redness, right? Often nocturnal onset mostly occur in First, metatarsophalangeal joint, right? Then fever and raised inflammatory markers may occur, right? Chronic disease can cause tophi and joint damage. Even- Yeah, done. So those are the clinical features. Other than that, you should know about the risk factors. So what are the risk factors? A strong family history of gout, drugs that inhibit renal excretion of uric acid, like thiazide diuretics, loop diuretics, cyclosporin, and consumption of purine-rich food, consumption of alcohol, consumption of fructose, sweetened drinks, disorders involving high cell turnover like hematological malignancies or severe psoriasis, obesity, hypertension, chronic kidney disease, dyslipidemia, type 2 diabetes, and catabolic state, dehydration. So, um, clinical features of gout. Okay. First acute attack of gout is usually monoarticular and often occur in the big toe. The first metatarsobopharyngeal joint, right? Or another part of the symptoms manifest rapidly, often during the night or early morning. The joint is usually very painful and red and swollen. The first attack can be severe and may mimic septic arthritis. Patient may present with fever, malaise, leukocytosis, and elevated inflammation markers. If the acute attack is not treated, symptoms usually subside over few days to 1 to 2 weeks, right? In female, the first attack may be polyarticular, typically in the hands and with gouty tophi. The presentation may be an acute inflammation in joints already affected by arthritis. Gout rather than a flare of osteoarthritis suggested by a presence of tophi and acute onset inflammation. Example, in elderly female who may also be taking diuretics, right? So most patients who are not started on urate lowering therapy will have second acute attack of gout within 2 years. Ischemic heart disease, hypertension, and chronic kidney disease are independent risk factors for recurrent attack. Recurrent attack Recurrent attack may be misdiagnosed as sprain or other soft tissue injury. Initially, recurrent attack may be separated by long intervals of relatively normal joint function. Eventually, recurrent attacks occur more frequent. Like in the beginning, the attack frequency is very little, right? But in later, patient is having recurrent frequent attacks, right? And then you should know what are the clinical features of chronic gout. Okay, first of all, we should check gout. Here you can see the typical presentation of gout. Here, this is how it present. Where's gout tophi? Yeah, can you see the tophi? The white color. We will discuss, okay, in chronic. Okay, so what are the clinical features of chronic gout? If gout remains untreated, recurrent attacks may fail to resolve completely, slowly leading to chronic disabling destructive arthritis. Even in the absence of recognized recurrent attack, urate crystals can deposit in the joints, soft tissues, and kidney as well, leading to joint damage and chronic kidney disease. So, chronic gout may be oligoarticular or polyarticular and symmetrical. Involvement of the small joint of the hand can mimic rheumatoid arthritis or and psoriatic arthritis. Serum uric acid concentration may be also elevated in psoriasis due to increased cell turnover. Right? Then patient with chronic gout also experience acute attacks. We call it acute on chronic gout. Okay. Then gout tophi are frequently seen in patients with chronic gout, right? They are usually present in the elbow, knees, and peripheral joints. Chronic tophus gout is destructive and, unless treated, may cause significant disability, right? So the next thing, so diagnosis of gout. So how we should diagnose gout? How we should diagnose? Here, aspiration of affected joint or bursa is a gold standard for confirming the diagnosis of gout, right? So you should know aspiration of affected joint, right? Then here they have mentioned while a suspected diagnosis of gout can be made based on clinical assessment, a definitive diagnosis required the identification of monosodium urate crystal under polarized microscopy in synovial fluid or tophi. Confirmation of diagnosis important because gout usually require lifelong urate lowering therapy. Other than that, we need to exclude septic arthritis always, right? We will do questions, then you will understand. Then microscopy and culture of the synovial fluid should also be taken to exclude the infection septic arthritis. Once the definitive diagnosis of gout has been made, diagnostic aspiration is not required for recurrent attacks unless infection is suspected. The synovial fluid analysis is not feasible. Joint is difficult to aspirate or clinical diagnosis of gout support by the following features: monoarticular involvement of the foot or ankle, previous similar acute arthritis episodes, rapid onset severe pain and swelling, erythema, tophi, strong family history of gout, cardiovascular disease and hyperuricemia. These features are highly suggestive of gout but not specific to gout. Okay. Uh, yeah. While clinical context is important, ideally urate lowering therapy should not be started in someone without crystal proven disease, right? So, and serum uric acid concentration should be measured in all patients with suspected gout. However, the presence of hyperuricemia alone is insufficient to diagnose the gout. In patients with acute gout, serum uric acid concentration may be normal, right? Other than presence of tophi, individual clinical features, history of painful swollen big toe, that's the tophi, have a low diagnostic utility, right? So here monosodium urate crystal are not seen on plain X-ray because they are not radio opaque. A plain X-ray is useful to identify joint damage due to the gout and presence of radiographic damage in the indication of urate lowering therapy, right? The complex or difficulty case, a specialist may be used imaging modalities such as ultrasound or dual energy computed tomography in the diagnostic of gout, but their utility is uncertain. Imaging does not replace the joint or bursal aspiration, right? The gold standard is that, right? So, next one is management. Before that, you should know this criteria. I don't know, you already know this criteria. This is a very important criteria, okay? For septic arthritis and other inflammatory arthritis. So usually, mm, If you are familiar with septic arthritis, you know what is this, okay? Like when we doing the synovial fluid aspiration, synovial, this is a gout arthritis question. If you are comfortable with septic arthritis, you know this. Usually after aspiration of the synovial fluid, we have to check the WBC level, right? This is one of main criteria to diagnose the septic arthritis. If it is less than 2000, it's a non-inflammatory like osteoarthritis. If it is between 2000 to 50,000, it's inflammatory arthritis like gout, pseudoarthritis, or rheumatoid flare. If the WBC level is more than 50,000, it's septic arthritis is likely. Okay, please remember. And here, gold standard is joint aspiration, showing needle shape negatively bifringent monosodium urate crystal, right? Yeah. Here, synovial fluid. Here, it can be between 2000 to 50,000. Serum urate, it can be elevated or normal, right? Yeah. Okay, management we will discuss from here. Management also, you should know we have acute management and we have chronic gout management. We have flare prophylaxis. You should know. Okay, here, chronic gout, then urate lowering therapy, and drug regime of chronic gout. What they have mentioned. Okay, first start from. Sorry. So first start from the management of acute gout. Acute gout, okay? The aim of sorry. Yeah, sorry for that. The aim of acute gout management is provide rapid symptom relief because it's a very severe pain, right? It's a very severe pain. So we need to treat the acute symptoms, right? First acute symptoms. So that is our acute treatment management, right? Okay, so what are the drugs we can give me the example of drugs that we can use in acute management of gout? You should know. So what are the three drugs, main drug we can use? Mm, okay, NSAID, what else? So for acute management, we have three drugs, and we should know what are the indications and what are the contraindications of these three drugs. So what are those? Here, the drug choice is corticosteroid, NSAID, or colchicine. So these are the three drug of choice for acute gout management, right? Here, corticosteroid lower incidence of adverse effect than oral NSAID therapy. Can be given to population with comorbidities with NSAID are unable to use. So, what are the contraindications of NSAID? Tell me.
Renal disorder,
But
gastritis.
yeah, and gastric ulcers, right? Peptic ulcer disease. These two are the main contraindications, right? So you should know them. Then, what about NSAID? Higher incidence of adverse effect than corticosteroid in high risk population. Then colchicine, a small therapeutic window, risk of toxicity and adverse effect at higher doses. So they are recommending lower dose of colchicine. So let's check here. For here, what are those? Yeah, corticosteroid. A local corticosteroid injection at up to two affected sites for advising on drug choice and to affected side. Then prednisolone oral 15 to 30 milligram we can give either injection or orally until symptoms subside. Here, all of the NSAID listed below are equally effective, so we can choose any of these drugs. Celecoxib, ibuprofen, endomethacin. So all are here, all are one. This is the number two drug. So always go with this number one drug. Then the use of colchicine for acute gout is limited, but the short duration of treatment before toxicity occurs, colchicine may be considered for patients who have previously used it to successfully manage acute flare-up of gout. It is unlikely to be effective if not started within 24 hours of attack for rapid symptom relief of acute gout with colchicine use. So colchicine we can use 1 milligram orally initially, then 0.5 milligram 1 hour later as a single 1 day course. Total dose is 1.5 milligram. In addition, an NSAID can be used for symptoms relief. So when we should use, usually we consider this drug patient who have previously used it successfully. We prefer for these patients, right? And we should start this low dose colchicine, colchicine within 24 hours, right? Within 24 hours, but they are mainly recommending NSAID and corticosteroids. So please remember these two, okay? And these three are the main three of drug. But from these three, better to go with NSAID and steroid, okay? Yeah. Then, then you should know about the chronic gout management. So, principal pharmacological management of chronic gout. So, urate lowering therapy aims to achieve a serum uric concentration that dissolve exciting monosodium urate crystal in the joints, soft tissues, kidneys, and prevent the formation of new crystal and reduce the frequency and severity of acute attacks, eventually leading to the absence of acute attack and result of it. So, lifelong urate therapy is lifelong urate therapy. Oh my God, what is it? Okay. I just saw the chat doctors. There were so much messages, and I was thinking, what is going on the chat? Okay, so lifelong urate therapy is recommended for all patients with confirmed diagnosis of gout. So, how we should confirm the diagnosis of gout? What is the investigation of choice to confirm the diagnosis of gout? Quickly type in the chat. I'm just repeating these things because they are very high yield. Okay. Yes, joint aspiration, right? What we can see in joint aspiration? What we can see in joint aspiration? Okay, good. Okay. Yeah, good. Okay, let's continue. Okay, for all the gout patients who has confirmed the diagnosis, we should give lifelong urate lowering therapy to maintain the urate level of body, right? It's eventually help to do this. Like dissolve the exciting monosodium existing monosodium urate crystal and reduce the frequency of the attacks and reduce the severity of attack and resolve the torpor, right? So for that we can start the lifelong urate lowering therapy. Then yeah, and It can be safely started alongside treatment for acute gout attack. Starting or increasing urate lowering therapy is associated with the high risk of gout flare. So, flare prophylaxis is recommended. So, the next thing you should know about flare prophylaxis, we will discuss later. 1 minute. A conversion introducing urate lowering therapy should be started within all patients with confirmed gout. The importance of starting therapy much higher in patients with one or more of the following. One or more subcutaneous tophi, evidence of radiographic damage, two or more flares annually, patients who have experienced more than one flare after first gout attack can have higher serum urate with concomitant moderate severely kidney impairment for kidney stones, right? Yeah. Then what is okay? So target serum uric concentration. So people with tophi, chronic arthropathy or frequent attack target is less than 0.3 millimoles per liter or 5 milligrams per deciliter initially until total crystal dissolution and resolution of the gout, then less than 0.36. Right? 1 minute. So, what is the normal urate level? Urate level. So, what is the normal urate level? What is the normal urate level, doctors? Tell me. What is the normal level, doctors? What is the normal level? You should know, right? What about February, doctors? Mm-hmm. Okay, it's 0.2 to 0.42 millimoles per liter, right? In milligrams per deciliter, how much is? Mm-hmm. Okay, should be less than 7, right? So here, so this is the target level. So people with non-tortious gout, it should be less than 0.36 or less than 6 milligrams per deciliter. Millimoles, doctor? Yeah, sure, I can repeat. 0.2 to 0.42. Okay. So, yeah. These are the target level. Here 0.3, here 0.36 without TOFI, with TOFI. Then failure to adjust the dose of urate lowering therapy to achieve the target serum uric acid concentration is common reason for the treatment failure. Once the target serum uric acid concentration has been achieved, urate lowering therapy should continue to maintain the target concentration less than 0.36. Lower levels of serum uric acid are not recommended over the longer term because uric acid might protect against some neurodegenerative disorder. So, what is the drug for urate lowering therapy? So, what is the drug for urate lowering therapy? It's the allopurinol, right? Allopurinol. So, let's discuss about allopurinol. And you should know in August exam, they have asked about the initial dose of allopurinol, right? So for that, you should know it. Mm, yeah, what's that part here? Allopurinol. Allopurinol 50 milligrams orally daily, then increase the daily dose by 50 milligram every 2 weeks or by 100 by every 4 weeks up to maximum 900. You should know the maximum dose and initial dose as well. Okay, so we will discuss about this flare prophylaxis later. Okay, first we will discuss about the urate lowering therapy. So it's allopurinol, the first line urate lowering therapy. So what is the second urate lowering therapy? And one more thing you should know about while using allopurinol. What is that? What is that, doctors?
HLA 15801 gene.
Yeah, here they have mentioned you should know in people with HLA-B 5801 gene mutation, patients with this gene mutation, we should not use allopurinol because that can aggravate the skin rash, right? So if the patient is presenting skin rash after allopurinol, we should immediately stop the allopurinol because it's a allopurinol hypersensitivity reaction. Here you can see usually in Southeast Asian ethnicity, especially the Han, Chinese, Korean, and Thai population. Allopurinol hypersensitivity syndrome is a contraindication to further exposure to allopurinol. So please remember this one as well. Then you should know about second line urate lowering therapy. So what are those? So if allopurinol is contraindicated or not tolerated at any dose, then we can use fibosoxstat, right? Fibosoxstat. Oh, I can't read this. Yeah. Fibosoxstat, right? Yeah. It's a xanthine oxidase inhibitor, or we can use probenecid. These two are the second line medications that we can use as lipid lowering therapy, right? Here, febusoxstat is not recommended for patients with pre-exciting major cardiovascular diseases. Febusoxstat should be used with caution in patients with hepatic impairment or moderate to severe kidney impairment. Then febusoxstat is also to reduce the metabolism of acetylcholine and mercaptolurine, increasing the risk of severe bone marrow toxicity. If possible, avoid the combination of febusoxstat with either acetylcholine or mercaptolurine. Then probenecid can increase the risk of urate nephrolithiasis and should be avoided in patients with non-urate nephrolithiasis, right? Yeah. Then, the next thing which you should know about flare prophylaxis. So you know what is the chronic gout management, and you know what is the acute management. The next one is the acute flare management. So let's discuss. So, in chronic gout management, okay, think like that. Okay, you should know lipid lowering therapy. Okay, one acute gout management. You know 3 types of drugs, right? Then you should know lipid lowering therapy. Then you should know what is the management of chronic gout, right? Chronic gout. So, chronic gout prophylaxis. So, here in chronic gout management, that include urate lowering therapy plus flare prophylaxis. Because, like, even though we are using lipid lowering therapy, there can be acute attacks, right? acute flare up. So in that case, what we can here, okay, prevention of gout flares when starting or change in urate lowering therapy. Starting or increase in urate lowering therapy is associated with high risk of gout flares. So flare prophylaxis is recommended. Colchicine has the strongest evidence as a prophylactic drug for gout flare and is well tolerated at daily dose of 500 micrograms. So NSAID may be considered for patients with whom colchicine is contraindicated or ineffective. When using NSAID, consider the benefits-harm ratio, particularly in patients with high risk of harm. The low dose of corticosteroid should be used with caution because long-term use associated with the adverse effect. If a patient has had recurrent flares of gout despite prophylaxis, a specialist may consider the combination therapy with colchicine plus either NSAID or prednisolone. Avoid concurrent use of NSAID or oral corticosteroid because significant increased risk of GI toxicity and NSAID are not likely to have additional benefits in patients taking oral corticosteroid, right? So colchicine has the strongest evidence as a prophylactic drug for gout flares and is well tolerated at a daily dose of 500 micrograms. Right here, patient may reluctant to take urate lowering therapy because previous acute attack precipitated by starting or increasing therapy. Started on a low dose urate lowering therapy, minimize the risk of flares, then dose is gradually increased until the target serum uric acid concentration achieved. Flare prophylaxis is recommended for all patients starting or change in urate lowering therapy. So please remember this one, okay? Flare prophylaxis is recommended for all patients starting what? Starting or change in urate lowering therapy. So what is the best drug for flare prophylaxis? They have mentioned colchicine, right? Colchicine. One minute. So here, flare prophylaxis is recommended for all patients. Yeah. Then here, this is the drug regime for chronic gout. So we have lipid lowering therapy plus flare prophylaxis. What is that? Allopurinol plus colchicine. There's a strong consensus that allopurinol should be used as first-line urate lowering therapy. A two-drug regime initially for urate lowering therapy and flare prophylaxis in choice of gout. We can use these. Colchicine alternatively need for flare prophylaxis consider NSAID of oral corticosteroid. Then the duration of therapy should be individualized because of the long-term use can be associated with unacceptable adverse effect. Limited treatment to the lowest dose and shortest duration of treatment for flare prophylaxis, chronic gout, we can use uh, celecoxib, heterosoxib, so these are NSAID, right? If the target serum uric concentration is not achieved with allopurinol, check adherence before altering the therapy because allopurinol therapy is really ineffective. Allopurinol therapy, yeah, the same thing. If the target serum concentration, sorry, uric acid concentration cannot be achieved despite adherence, probenecid may be added to allopurinol, right? When we should add, in previously we have discussed about when there's a contraindications, right? Here patient is adherence also good and everything is like perfect but still having high uric acid concentration. In that case we can add probenecid to allopurinol. Yeah. And if allopurinol, yeah, the same thing, doctors. Yeah, that's all for that's all for gout. Yes, doctor. Yeah. As example, patient is already on. already on lipid lowering therapy, and patient is having some flares, acute symptoms. In that case, to prevent that, not to treat acute situation, to prevent that, we have to start flare prophylaxis with the starting of urate lowering therapy. Okay, in gout you should know the acute treatment, like acute situation treatment. Then what else? You should know lipid lowering therapy, and you should know how you should treat chronic gout. Chronic gout should treated by combination of therapy. How? Lipid lowering therapy plus flare prophylaxis. Why? Because even though patient is taking a lipid lowering therapy, patient can have flares, right? Acute gouty attacks. So to prevent that, as a prevention, not the acute treatment, as a prevention, we can start this combination therapy with lipid lowering drug as allopurinol plus colchicine to prevent these acute attacks while taking the lipid lowering drug. So that's all for this one, the gout. Hope you understand everything. It's not very hard, very simple. Let's check here the same thing. Hmm, okay, we'll do some questions. Yeah, we'll do some questions for gout. 1 minute. The thing is, doctor, I'm having a cough. I really hard to like speak. So, but today I'm not sure. Now also I'm not actually feeling good. I don't have any flu or anything, but like I'm having some cough. So it's very hard to breathe. So we'll do some questions and after let's see. 1 minute, I'll select from the question. I will do SLE, but not today. Please wait few minutes. I'm okay. So I have selected few questions. Let's do that. Okay, so a 92-year-old woman present to the GP clinic with her daughter for her annual health assessment and repeat prescription medications. She has a medical history of glaucoma, type 2 diabetes, hypertension, gout, and osteoarthritis. Her medications include perindopril, aripiprazole, hydrochlorothiazide, paracetamol, and metformin. So, on examination, she appears well with normal vital signs. Her daughter has noticed multiple lesions on her hand and asks what they are. The patient state they don't cause her any pain or and have been there for many years, slow growing over the time. Okay, this is the picture. Which one of the following is most likely to diagnose of this lesion? Nodular basal cell carcinoma, trophy, a synovial crystal rheumatoid nodule, epidermoid cyst. Okay, let's check. Yes, why? The image demonstrates the classic tophi secondary to uric acid deposition in the setting of patients' known history of gout. Tophi are depositions of monosodium urate crystals that typically occurs in chronic gout. They are often painless and can grow slowly over the time. Tophi are commonly found in the hand, feet, or other area of the lower temperature. Here, tophi are depositions, same. The tophi can be painless and grow slowly over time. Tophi are often found in hand, feet, and other areas of lower temperature. So, here, 82-year-old woman present to the emergency department with 3-day history of severe neck pain and reduced range of movement. She has recently undergone undergone multiple steroid nerve root injection for her left shoulder for osteoarthritis with minimal benefit. She has a medical history of osteoarthritis, gout, and type 2 diabetes, hypertension, ischemic heart disease, dyslipidemia, chronic kidney disease, osteoporosis, and glaucoma. Our regular medications include metformin, perindopril, then atorvastatin, aspirin, timolol. Then several medications were recently ceased due to polypharmacy concern, including allopurinol, which she has been taking for 5 years. On examination, appears uncomfortable. Appeared uncomfortable. Is uncomfortable. Pulse rate 82, BP 145 by 85, respiratory rate 16, SpO2 97, and temperature 37.1. She has reduced range of movement in the neck in all direction and it's tender over her midline C4 joint. Neurological examination is normal investigation. Hemoglobin 128, white cell count 8.2, platelet 290, C-reactive protein 80, erythrocyte sedimentation rate or ESR 50, increased, right? Creatinine 145, estimated EGFR 35, X-ray of the cervical spine shows the degenerative changes. So, which one of the following is most likely diagnosis? This is the question. This is the answers. What do you think, doctors? What do you think? What about other doctors? Thank you so much, Dr. Supriya. I just saw the message. Let's check your answer. Yes. Patient present with acute neck pain shortly after stopping the allopurinol with elevated ESR and background of multiple risk factors for gout, which cervical spine involvement is uncommon. Spinal gout should be considered, particularly given the recent withdrawal of allopurinol, which can precipitate acute attack, right? Yeah. So 54-year-old man present to the GP clinic with immense pain in his hand and wrist, which started a couple hours ago. He complains of similar episodic pain for many years and described the occurrence of initially as occurrence start a couple hours. 1 minute, sorry. He complained of similar episodic pain for many years and described the occurrence initially as unilateral, which then developed into the bilateral sudden attack over the time. He has not seen a doctor for more than 10 years due to financial problem. He has a medical history of chronic kidney disease from a young age due to the congenital kidney malformation. His medications include NSAID, which help to relieve the pain, For acute flares of joint on physical examination, multiple painless hard nodules which with joint deformities of the hand like this and hardened nodules around the pinna of the external ear also noted. Which one of the following is the next best step of the management? What do you think? What do you think, doctors? This is the question. What do you think? Quickly answer. What about other doctors? Okay, we got B's and A's. Let's check how many. We got two A's and one B's. What about other doctors? Quickly answer. Okay, most of doctors are going with A, right? So let's, no, A or B. No, A, right? Most of doctors are going with A. Let's check. You correct or not? Okay, now tell me why A, why you select A. Is this is an acute situation or not? Patient with immense pain in his hand and which started couple hours ago. Is this an acute attack or not? Acute attack or not? Okay, this is acute attack. Complaints of similar episodic pain for many years. Okay, he already had a gout, right? Yeah, and even though he's already having a gout like chronic gout, still this is an acute attack, right? Okay, let's read this. The patient has acute on chronic gout with extensive soft tissue tophi as the crystal deposition also found in the pinna of the external ear. Do you remember this part? That time also I told you here. Not clinical features. Where was we discussed? Yeah, I think. Here, acute on chronic gout. Do you remember this one? Even though patient in chronic situation, patient is can have some acute attack, right, with severe pain, redness, and everything. That was the kind of scenario here. So let's check why first line management in this case acute gout flares anti-inflammatory therapy such as colchicine, NSAID, or glucocorticoid. However, since the patient has a history of chronic kidney disease, colchicine and NSAID, which are nephrotoxic, should be avoided, and glucocorticoids the best answer. So why you didn't select that? Here, it's an acute situation. It's fine. We will do next question. A 81-year 81-year-old woman with known diabetes and chronic kidney disease is admitted for hypertensive crisis on the third day of her hospital stay. Through her blood pressure well controlled, she complained right knee pain. There is no history of any trauma or she's on metformin, furosemide and perindopril. On examination, her weight is 74 kilograms, height is 164, blood pressure 128 by 80, pulse 90, temperature 37.2. Examination, her right knee shows a tenderness, erythema, and swelling, but the full range of motion present. Aspiration of synovial fluid shows a needle-shaped crystal and no features of septic joints. Serum creatinine 212, urea 12.5, then serum uric acid 0.51, and random blood glucose 12.1. Which one of the following most appropriate management? Tell me, doctors. This is the question. What about other doctors? Okay, let's check. Why C? Tell me why C. Here demonstrate acute attack monoarticular gout in the elderly person with comorbidities, diabetes, and chronic kidney disease. So we don't have to discuss furthermore. We know what's the answer, right? It's intraarticular corticosteroid. Minute. So 70-year-old woman present to the GP clinic with painless swelling of multiple finger joints and that has gradually worsened over the past year. The swelling now interferes with her activity of daily living. She has 15-year history of recurrent episodes of acute joint pain and swelling, which she has managed with short course of ibuprofen. Her medication include hypertension, nephrolithiasis 10 years ago. She takes amlodipine but has avoided other regular medications. On examination, she appears well with vital signs in normal limits. Finger shows multiple firm white yellow nodule deposits on the joint with associated deformity. So, which one of the following is most likely to diagnosis? Yes. Yeah, you're correct. So the next one, 55-year-old man to the GP practice with 3-day history of severe pain in the first metapharyngeal joint of his right foot. He has a medical history of alcohol dependence. Drink one cask of wine per day. Hypertension, type 2 diabetes mellitus, diet control, myelodysplasia, and gout. His regular medications include allopurinol and perindopril. On examination, he appears well with vital signs with normal limits. First metatarsal joint of his right foot is red, swollen, warm, and exquisitely tender to touch with restricted range of movement. Blood tests show creatinine 122, urea 10, urate level 0.6. Which one of the following is most appropriate treatment? What do you think, doctors? And what other doctors? Okay, let's check your correct one. Why? Patient present with acute flare of gout affecting single joint. The management options for acute gout include NSAID, colchicine, and glucocorticoid. So, here, intraarticular methylprednisolone is the most appropriate choice in this case. What is in the chat? In case with monoarticular involvement, local glucocorticoids injection provide rapid relief uh, while avoiding systemic effect, right? So, done. Okay. Okay, this is for investigations. 84-year-old man presented to the emergency department with 3-day history of severe pain, swelling, and redness of his left hand. He has medical history of psoriasis, gout, type 2 diabetes mellitus, hypertension, and osteoarthritis. His regular medications include secukinumab, allopurinol, colchicine, metformin, gliclazide, perindopril, and paracetamol. He has a recently had reduced oral intake following gastrointestinal illness. On examination, he appears uncomfortable but not distressed. His pulse rate is 82, blood pressure 138 by 85, respiratory rate 16, SpO2 98, temperature 37.2. His left hand shows a diffuse erythema and swelling with marked tenderness over the distal and proximal interphalangeal joints of the second finger. Multiple chalky white nodules are visible around these joints, which has plaque psoriasis present on his bilateral upper lip. Investigation WBC 13.5, C-reactive 55, sodium 138, potassium 4.2, creatinine 136. X-ray of the left hand shows the erosive changes with overhanging edges and second finger of interphalangeal joint and soft tissue swelling. Which one of the following most appropriate next step in? What do you think? Mhm. Okay, most of doctors are going with D, and one doctor is going with E. Let's check. Let's give priority to maturity. Let's check why, okay? This patient presents with acute gout flare with visible tophi, chalky white nodules, which are pathognomic for chronic gout. No further investigation required to make the diagnosis in this case, as the presence of tophi is highly suggestive for the diagnosis of gout. The joint aspiration is gold standard for diagnosing acute gout in case where the diagnosis is uncertain, as it can demonstrate negatively bifringate urate crystals under polarized light microscopy. However, it is invasive and unnecessary when tophi are already visible. So, it's a good point. So, tophi are pathognomic for gout and established diagnosis without need for further investigation. Joint aspiration remains the gold standard for diagnosing acute gout when the diagnosis is uncertain. Dual energy CT can detect the quantify urate deposits, so it's not necessary while tophi are visible. Okay. So 68-year old old woman present to the emergency department with 3 days of severe pain, swelling, and redness of his right shoulder. He has a medical history of hypertension, osteoarthritis, and previous thyroidectomy. For multinodular goiter, its regular medications, amlodipine, paracetamol, and thyroxine. Examination, he appears uncomfortable. His pulse rate 88, blood pressure 145 by 85, respiratory rate 16, SpO2 98, and temperature 37.8. Right shoulder is warm, swollen, and tender with limited range of motion. Active and passive movements limited with the pain. Uh, Arthrosynthesis is performed, yielding cloudy synovial fluid, which is sent for microscopic examination. Which one of the following microscopic finding most likely to be seen? What do you think, doctors? Okay, you are going with B. Let's check. Let's check why, okay? The patient present with acute monoarthritis of shoulder, which is common site of calcium pyrophosphorate deposition disease, or we call it pseudogout, right? The patient's history of thyroidectomy is significant, as thyroid disease is a known risk factors for pseudogout. Positively birefringed rhomboid crystals are characteristic of pseudogout. These crystals appears blue when aligned parallel to uh, compensator and yellow when perpendicular under compensated polarized light microscope. So negative bifringe needle shaped crystals are characteristic of gout caused by monosodium urate crystal deposition. Gout typically affect the uh, first metatarsopharyngeal joints, ankles, and the same thing. Let's check again. Okay. So we have done enough amount of questions, right? Okay, here we will discuss this one as well. 52-year-old man present to the GP clinic with 3 days of severe pain and swelling in the his right big toe. He underwent renal transplant 2 years ago for end-stage kidney disease secondary to polycystic kidney disease. His medical history include hypertension, dyslipidemia, and examination. His right first metatarsopharyngeal joint is swollen, erythematous, and exquisitely tender to touch. The patient is commenced on xanthine oxide inhibitors, which one of the following immunosuppressive medication used in renal transplantation may cause potentially serious interaction with this newly commenced medication. Why? Why this? The patient in this scenario presenting symptoms of typical acute gout. The common complication is renal transplant repair. The treatment initiated as xanthine oxide inhibitors, likely allopurinol, is standard therapy for gout. However, the transplant patient's medication interactions are critical considered. So, azathioprine is an immunosuppressive medication that can use potentially serious interaction with allopurinol. Yeah. Okay, then inhibition of xanthine oxidase by allopurinol decrease the rate of conversion of azathioprine and mercapturia in inactive metabolites. We have discussed this, right? The subsequent increase of plasma concentration of active metabolites may lead to the life-threatening myelosuppression, which increases the risk of infection is already immunosuppressed and renal transplant patient. Right. Just actually, it's very hard me to read everything right now. So I'll do extra hour in tomorrow because my throat is hurting and it's so much. I always there is a cough reflex, so it's very hard me to do another session. I don't know what happened to my throat today. So tomorrow I don't have my recall class, so I can start bit earlier and we can continue. Okay. And thank you so much, doctors. I have to stop the session right now. So we will continue tomorrow and I will do some more questions. Yeah. Thank you so much. Yeah. Thank you so much, doctors. Yeah, we will meet tomorrow. I will do an extra session, so don't worry. And this week, I will do some statistics and ethics topics as well, because one of most important topics in ethics is mandatory notification. So we should cover that as well. So don't worry. We will try to cover as much as we can, right? Yeah, don't worry. We have February doctors as well, so we will try to help them. Thank you so much, doctors. I will meet tomorrow. Bye bye. Have a good day.